I want you to picture a scene. It's a scene that plays out in hospitals all over the world, usually when the rest of the city is, well, dead asleep.
The 2 a.m. shift.
Exactly. It's
Yeah.
2:0 a.m. The air conditioning in the emergency room is humming that low, monotonous drone. You're under these harsh, unforgiving fluorescent lights that make everyone look a little bit gray.
It's the classic lonely hour of the profession.
Right. And standing there, hovering over a gurney, is a surgeon. And in front of the surgeon is a human being in absolute agony. Belly distended, maybe screaming, or maybe they're actually too weak to scream.
Which is often worse.
Yeah. And the surgeon is holding a scalpel, metaphorically at least, and they're staring down the barrel of the single most difficult decision in their entire career. It's not, how do I cut? It's, do I cut at all?
To cut or not to cut. I know it sounds like a cliche, but that binary choice is the absolute crucible of emergency surgery.
So we are diving deep today into a source that explores this exact moment. It's a transcript from the Surgical Thinking Academy, specifically a deep dive titled The Wisdom of the Knife.
A fantastic piece of material.
It really is. And what I loved about this source material is that it doesn't read like a dry medical textbook. It reads more like a confession. It's raw, it's full of sensory details, and it actually starts with this incredible comparison to Shakespeare.
Right. Hamlet, the Prince of Denmark.
Yeah.
The source argues that Hamlet would have been a terrible surgeon, or perhaps a fascinatingly dangerous one.
Just because he couldn't make up his mind.
Well, actually, the source flips it a bit. They suggest that if Shakespeare were a surgeon, he might have operated just for the sheer drama of it, the action hero complex.
Ah, I see.
But the source makes this really profound point right at the start. Real surgical wisdom isn't about the drama of the intervention. It's about the discipline of restraint. It's about knowing exactly when not to operate.
And I think that's our hook for today. We tend to think of surgeons as these, well, mechanics who just want to get under the hood and fix the engine right away.
Just start wrenching.
Exactly. But this deep dive is going to completely dismantle that image for you.
Yeah.
We're looking at a transfer of street smarts from a senior surgeon who has literally spent decades in the trenches.
Decades.
So we're going to talk about the sights, the sounds, and warning to anyone eating lunch right now, the smells of the emergency room.
We are talking about intestinal obstruction.
Which honestly just sounds like a plumbing problem.
It is a plumbing problem,
Yeah.
but it's a plumbing problem happening inside a living, breathing, incredibly delicate metabolic machine. And if you get the repair wrong, the machine shuts down permanently.
So what is our mission here, aside from grossing everyone out a little bit?
Our mission is to really get inside the mind of that senior surgeon. We want to move way beyond the textbook flashcards. We want to help you understand the logic, the physiology, and the intense detective work required to save a life when the human gut simply stops working.
Let's start with the physiology then. When we say obstruction, I think most people imagine a clog in a drain pipe. Water hits the clog, water stops. Is it that simple in the human body?
Conceptually, yes. But physiologically, it's a total disaster. The source categorizes the blockage into 3 areas, just to keep it simple.
Okay.
It's either inside the lumen, which is the hollow part of the tube, or it's in the wall of the tube itself, or it's something entirely outside the tube squeezing it shut.
Okay, so the pipe is clogged from the inside, the pipe is swollen shut, or someone is physically standing on the hose.
That's the mechanics of it. But here's where we need to deepen the understanding for you. Because the body isn't a passive copper pipe. When you block the intestine, the body reacts violently.
Right.
The source lists the classic 4 symptoms: colicky abdominal pain, vomiting, distension, and absolute constipation.
Absolute constipation meaning nothing at all.
No gas, no stool, total gridlock. But if we stop there, we actually miss the real danger. The source touches on this, but let's expand on it a bit because it's crucial.
Yeah, let's break that down.
When the bowel is blocked, it doesn't just sit there quietly. It keeps working. It keeps secreting fluids. We're talking gastric juices, bile, pancreatic enzymes.
How much fluid are we talking about?
Liters. Liters of fluid every single day.
And if that fluid can't go down the drain,
It gets trapped. And this leads to something called third spacing. This is a concept that the source alludes to, but it's critical for you to understand if you want to think like a surgeon.
the spacing.
Yes, the fluid isn't in the blood vessels anymore where it belongs, and it's not being absorbed back into the body. It's just pooling in the gut. So the patient becomes incredibly dehydrated, hypovolemic, even though their belly looks absolutely full of liquid.
So they are effectively bleeding to death internally,
Mhm.
but it's not blood, it's their own digestive fluids getting locked away in this trapped space.
That is a terrifying but highly accurate way to put it. Their blood pressure drops, their heart rate spikes. That's tachycardia because the heart is desperately trying to pump a smaller volume of blood much faster to keep the brain alive.
Wow.
So before the surgeon even worries about the physical blockage bursting, they have to worry about the patient going into hypovolemic shock.
That really explains the urgency. It's not just that they're uncomfortable. The clock is ticking on their entire circulatory system.
Exactly.
Now, let's go back to those 4 symptoms. The source emphasizes that they don't all happen at once. It's a sequence.
Right, it's a choreography, and this is where the surgeon has to step up and be a detective. The location of the blockage completely dictates the dance steps.
So let's break down the high obstruction versus the low obstruction. High obstruction means small bowel, right? Up near the stomach.
Correct. Proximal small bowel. If you put a dam right near the source of a river, what happens?
The water backs up immediately.
Right. So in a high obstruction, vomiting is an early sign. The patient starts retching almost as soon as the blockage happens. But because the blockage is so high up, there aren't miles of intestine below it to fill up with gas and fluid.
So they don't get that pregnant look.
Exactly. Minimal distension. You might have a patient who is just puking their guts out, but their stomach looks relatively flat.
Which is confusing.
Very. It can be incredibly deceptive if you're a junior doctor just waiting for the classic bloated belly to appear before you call surgery.
You're waiting for a sign that just isn't coming. Now contrast that with a low obstruction.
Large bowel, way down the line. Now you have 20 feet of small intestine acting as a massive reservoir. It can hold a huge amount of material. So what happens first?
The tank fills up.
Distension, massive distension. The patient looks like they are 9 months pregnant. They are deeply uncomfortable, they're bloated, but they might not actually vomit for hours or even days.
Just because it takes that long for the backup to reach the stomach.
Precisely. Vomiting is a late sign in low obstruction, and this brings us to one of the most visceral, memorable parts of the source material, the rite of passage.
Oh God, I read this part and I actually gagged a little. We have to talk about it though. Faculent vomiting.
It is exactly what it sounds like.
It's poop.
It's the contents of the lower small bowel. It's been sitting there, stagnating, fermenting with bacteria because it can't move forward. Eventually, the pressure gets so unimaginably high that the valve between the small and large intestine is overwhelmed, or the backup just physically reaches the stomach.
Yeah.
And when the patient finally vomits,
It smells like feces.
the source describes this incredible anecdote. A junior resident almost joining the patient in sickness because the smell was so violently overpowering, it permeates the entire emergency room instantly.
It's horrific, but the source makes the very real point that this is a critical diagnostic tool.
It is. If you smell that, you know 2 things immediately without even touching the patient. 1, this is a low obstruction. And 2, this has been neglected for a long time.
Because it takes time to ferment.
Right. It's a late sign. That smell is the smell of a system that has completely and utterly failed.
It's the body literally screaming that it's in crisis.
And for the surgeon walking into the room, it changes the entire calculus. You aren't dealing with a fresh problem anymore. You're dealing with a disaster in progress.
Okay, so we've established the what. The pipe is blocked. But the source introduces a critical distinction here that apparently confuses medical students all the time. The difference between mechanical obstruction and a functional obstruction.
Or alias, as it's called medically. This is the fork in the road. If you go down the wrong path here, you can very easily kill the patient.
Mechanical seems pretty straightforward. That's the physical wall we've been talking about.
Right. A tumor, a thick scar, a hernia. The road is blocked by a physical boulder. The bowel is working perfectly fine, the engine is running, but it physically cannot get past the boulder.
And functional.
Functional obstruction, or ileus, is when the road is wide open. There is no boulder anywhere, but the car has simply run out of gas.
The source compares this to a lazy employee.
I loved that analogy. The bowel has simply gone on strike. It's paralyzed.
Why would it do that?
This often happens right after major abdominal surgery, or if there's a severe infection somewhere else, or even just an electrolyte imbalance, like low potassium. The nerves that trigger that squeezing motion peristalsis, they just stop firing.
So the bowel is just lying there, completely flaccid.
Exactly. It's filling up with gas and fluid, not because it's physically blocked, but because it absolutely refuses to push anything forward.
And how do you tell the difference? You can't exactly look inside without cutting them open.
You use your ears. This is where the simple classic stethoscope is infinitely more valuable than a multi-million-dollar CT scanner.
The sound of surgery.
Think about the mechanical obstruction again. The bowel is healthy. It's actively fighting a blockage. It's squeezing harder and harder to overcome that wall. What does a desperate struggle sound like?
It's noisy.
It's very noisy. The source describes it as tinkling. High-pitched metallic rushing sounds. It sounds exactly like water rushing through a narrow pipe under very high pressure. Borborygmi is the fancy medical term, but tinkling is what you actually listen for.
And the lazy employee. The alias.
Absolute silence.
Just dead air.
The source calls it like an empty concert hall. You put your stethoscope on the belly and you listen, and you hear nothing. It's eerie. It's the sound of physiological silence.
That gives me chills. It's like listening to a city after an apocalypse.
It is ominous. And the treatment is completely fundamentally different. If you have an ileus, a paralyzed bowel, and you take that patient to surgery to fix it, you are doing the worst possible thing you could do.
Why?
You're cutting into a bowel that just desperately needs rest and chemical correction. You're traumatizing an organ that is already on strike. You're just making it angrier.
You're whipping a tired horse.
Worse.
Yeah.
You're shooting the horse because it's tired. But on the flip side, if you have a mechanical obstruction like a strangulating hernia and you treat it like an ileus by just waiting and giving it rest, the bowel dies.
So that one single listening moment, the tinkling versus the silence, is quite literally a life or death distinction.
It is the first major branch of the entire decision tree.
Okay, let's assume we've heard the tinkling. We know something is physically blocking the path. Now the detective work shifts to identifying the usual suspects. The source breaks this down by anatomy, starting with the small bowel. Who is public enemy number one?
Adhesions, without a doubt.
These are internal scars, right?
Yes. If a patient has ever had abdominal surgery, an appendectomy, a C-section, anything at all, scar tissue naturally forms as they heal. Usually it's completely fine. But sometimes these fibrous bands of scar tissue form little bridges or tight loops, and years later the bowel can get caught in them or kinked by them.
The source has a great rule of thumb here. If a patient has a surgical scar and an obstruction, assume adhesions until proven otherwise.
It's a probability game. It is by far the most common cause worldwide in the Western world. But there's a big catch.
Patients lie.
Or they forget, or they don't think it's relevant. You ask a guy in triage, have you ever had surgery? And they competently say no. Then you lift their shirt and you see a faint, faded white line on the lower right abdomen from an appendectomy they had in 1982.
The scar tells the truth.
The body keeps the score. The surgeon has to trust their own eyes more than the patient's memory. If you see a scar, you immediately know what you're likely dealing with.
Okay, suspect number 2 for the small bowel. The source calls this the most embarrassing cause to miss. Hernias.
This is a massive pitfall for young doctors. A hernia is basically a hole or a weakness in the muscle wall of the abdomen where the bowel physically pokes through. It creates a visible bulge under the skin.
Which should be obvious, right? I mean, you're looking right at them.
You would think so. But in a busy ER, maybe the patient is modest. Maybe they are wearing thick, tight underwear. Maybe the doctor immediately orders a fancy CT scan, but never actually fully undresses the patient to look at their groin.
The source tells a really sad story about an elderly lady here.
A strangulated femoral hernia. The femoral canal is this tiny, very tight space near the groin, slightly lower than where you get the standard inguinal hernia. It's a very rigid, tight ring, which means if a piece of bowel slips in there, it gets strangled incredibly fast.
And they just completely missed it.
They did all the blood tests, they treated her for dehydration, they gave her pain meds, but nobody actually lifted the sheet to physically examine the femoral region. By the time they finally found it, the bowel was completely dead.
That is heartbreaking, especially since it's such a simple, non-invasive physical check.
It's a harsh lesson in humility. The source issues a stern warning. Always examine every hernia orifice: inguinal, femoral, umbilical, incisional. It doesn't matter if you have $1 million MRI machine right down the hall. If you don't physically put your hand on the groin, you can kill the patient.
Let's move down the track to the large bowel. The suspects change here. It's not usually adhesions in the large bowel, is it?
No. In the large bowel, the landscape gets much darker. The most common cause is cancer.
Carcinoma.
Specifically in the sigmoid or the descending colon on the left side. The source is very blunt about this. If you have an older patient presenting with a large bowel obstruction, you assume it is cancer until you definitively prove it isn't.
That's a really heavy assumption to walk into a room with.
It is, but it completely drives the urgency of the workup. You're not just clearing a temporary blockage anymore, you're potentially diagnosing a life-altering malignancy.
But there's another suspect in a large bowel, one that I found particularly fascinating just because of the striking visual: sigmoid volvulus.
This is a fascinating condition of geography and diet. It's very common in places like India, Africa, and parts of Eastern Europe, where the traditional diet is very, very high in fiber.
Wait, why does fiber cause a blockage? I thought fiber was supposed to keep things moving.
It does, but high fiber over decades makes the stool very bulky, and constantly moving bulky stool physically stretches the colon over a lifetime. The sigmoid colon, the last part before the rectum becomes redundant, it gets abnormally long and floppy.
Redundant is a very polite medical way of saying it's way too long for the space it's housed in.
Exactly. So you have this long, incredibly floppy loop of bowel just sitting in the pelvis, and just like a long garden hose, if you twist it, it kinks. That twist is a volvulus. The bowel twists around its own mesentery, cutting off its own blood supply.
And the visual, the X-ray sign.
The coffee bean sign.
I looked this up while prepping. It really does look exactly like a giant coffee bean taking over the entire abdomen.
It's unmistakable. You see this massive, black, air-filled loop of bowel rising up from the pelvis. It's shaped exactly like a coffee bean, complete with a thick central white line down the middle where the two inner walls of the twisted loop are touching each other.
The source mentions that treating this is actually one of the big wins of the profession, because you can sometimes fix it without ever making a cut.
This is the magic trick aspect of surgery. Because it's a physical twist, not a solid tumor, you can sometimes literally untwist it from the inside.
Using a flatus tube.
Or a flexible sigmoidoscope. You carefully guide the tube up through the rectum, navigating blindly toward the twist, and the exact moment you pass the point of the twist.
Whoosh, whoosh.
All that trapped gas and liters of toxic fluid rushes out through the tube. You literally deflate the patient like a balloon. The belly goes flat instantly. The pain vanishes in seconds. It's incredible instant gratification.
That must be profoundly satisfying for a surgeon.
It's beautiful. You've saved the patient from a massive, dangerous laparotomy with just a rubber tube and some basic physics. It's an elegant solution.
Okay, so we've done all the detective work. We've checked for scars. We've listened to the belly for tinkling or silence. Maybe we've seen a massive coffee bean on the X-ray. Now we arrive at the absolute climax of the deep dive, the million-dollar question.
To cut or not to cut?
The source vividly describes the sleepless nights associated with this specific decision. But why is it so hard? If you know they are blocked, why not just operate immediately to be safe?
Because surgery isn't free. I don't mean financial cost. I mean physiological cost to the patient. Anesthesia is dangerous. There's a high risk of infection. And ironically, cutting them open creates a massive risk of creating more adhesions for the future. You don't want to open someone up unless you absolutely, positively have to. But if you wait too long,
The bowel dies.
the bowel dies. And dead bowel becomes permeable. It leaks billions of toxic bacteria directly into the sterile abdominal cavity. And that bacteria causes peritonitis, which leads to sepsis. And sepsis kills very quickly.
So what is the red line? What is the unmistakable signal that tells the surgeon, okay, the waiting game is officially over, we go to the OR right now?
The red line is strangulation.
We've used that word a few times today. Let's define it exactly for you in this context.
Strangulation means the physical blood supply to that specific section of bowel has been completely cut off. The blockage isn't just stopping the food and fluid anymore, it's physically pinching the arteries and veins.
So the tissue is literally suffocating.
It's becoming ischemic. And the timeline for ischemia is brutally fast. You have hours, not days. If you miss the signs of strangulation, the patient will likely die.
How does the surgeon actually know? What changes in the patient lying on the bed?
The character of the pain changes. This is absolutely critical. Remember we said the classic obstruction pain is colicky, waves of intense cramping followed by relief?
Right, it comes and goes.
That's the healthy bowel fighting the blockage. But when the bowel actually starts to suffocate and die, the nerves in the abdominal lining get deeply irritated by the localized inflammation. The pain changes, it becomes constant, unrelenting. The patient completely stops moving. They lie perfectly still on the bed because every single micro movement is agony.
And they start to look toxic.
That's the clinical term we use, toxic. Severe tachycardia, high fever, plummeting blood pressure. They look pale, sweaty. They look like they are rapidly fading away right in front of you.
And if you touch their belly during this phase,
Extreme tenderness and guarding. If you press gently on that spot, their abdominal muscles will violently spasm involuntarily to physically block your hand from touching the dying organ underneath. That is the body screaming, "Do not touch me, I am dying in here."
If you see that rigid guarding, the debate in your head is over.
Immediately, you prep the OR, there's no more waiting.
There's another terrifying scenario mentioned in the source, the closed loop danger. Is this different from strangulation?
It's essentially a high-speed setup for strangulation. Imagine a single loop of bowel is blocked at the front and at the back simultaneously. Maybe it's caught under a tight band of adhesion at two separate points.
So nothing can get into the loop, but nothing can get out of it either.
Exactly. But the terrifying problem is the lining of the bowel inside that trapped loop is still actively secreting fluid and mucus. So the pressure inside that closed-off section rises exponentially. It's exactly like overinflating a balloon with a tap that won't turn off.
And it bursts.
It bursts incredibly fast. The wall gets stretched so thin that the blood vessels are crushed, it dies, and it pops. A closed-loop obstruction is an absolute surgical emergency. You cannot wait on that.
Okay, those are the definitive go signals, but let's talk about the stop signals. The title of the source is The Wisdom of the Knife. But a huge portion of that wisdom is actually about having the discipline to put the knife down. What exactly is conservative management?
This is usually deployed for adhesive obstruction, those scar tissue cases we talked about, where there is absolutely no sign of strangulation yet. The patient is in a lot of pain, but it's still colicky. Their heart rate is relatively normal. Their belly is still soft, not rigid.
So the bowel is stuck, but it's very much alive.
It's alive and it's highly annoyed. Conservative management is basically putting the bowel on strict bed rest. The hospital protocol is often colloquially called drip and suck.
Which is not the most appetizing name I've ever heard.
It's highly descriptive, though.
No.
The drip refers to the IV fluids. You have to aggressively rehydrate them directly into their veins because of that massive third-spacing fluid loss we talked about earlier. You have to fill the tank back up to protect the kidneys and the heart.
And the suck.
The nasogastric tube. The NG tube?
The plastic tube that goes up the nose and all the way down the back of the throat.
Yes. It goes down into the stomach, and it actively sucks all the backed up fluid and swallowed gas out.
But if the blockage is way down in the intestines, why does sucking fluid out of the stomach actually help?
It decompresses the entire system from the top down. It physically stops the patient from vomiting, which is a relief, but more importantly, it drastically reduces the physical pressure inside the gut lumen above the blockage. You're essentially taking the heavy load off the bowel so it can completely relax. And very often, if you just give it time and proper hydration, the swelling in the bowel wall goes down naturally, the tight kink unkinks itself, and normal flow restores itself.
All without a single cut.
Exactly. But doing this requires you to have absolute nerves of steel. You have to watch them constantly for 24 to 48 hours. You are in that room constantly re-examining them. Is the pain getting sharper? Is the fever suddenly spiking? Is the white blood cell count climbing?
It's highly active waiting. It's not passive at all.
It's arguably the hardest thing a surgeon has to do. Consciously doing nothing is often mentally much harder than just doing something.
The source mentions a really specific tool for this high-stakes waiting game. The Gastrografin challenge. It sounds like a viral internet challenge, but I assume it's highly medical.
It's a beautifully elegant solution. Gastrografin is a specialized water-soluble contrast dye. It shows up bright, glowing white on a standard X-ray. You have the patient drink it, or you just pour it directly down the NG tube.
Okay, so the dye is in the system.
Then you take an abdominal X-ray 24 hours later. If you see that bright white dye has made it all the way into the large colon, what does that instantly tell you?
It tells you something got through the bottleneck. The road is at least partially open.
Exactly. You've definitively proven the blockage isn't total. You know you don't need emergency surgery. But here is the absolute genius part of the challenge. Gastrografin is highly hyperosmolar.
Meaning?
It chemically draws water to itself, like a sponge. As it travels down the gut, it rapidly draws fluid from the tissues into the bowel lumen. This increases the local volume and pressure slightly, but more importantly, it heavily lubricates the entire system. It actually helps physically flush the sticky blockage through.
So the diagnostic test is also the actual cure.
In a huge percentage of cases, yes. It diagnoses the patency of the tube and treats the physical obstructions simultaneously. It's a brilliant two birds, one stone scenario that surgeons absolutely love.
That is incredibly clever. It feels like leveraging fluid physics to solve a complex biology problem.
That's exactly what it is. It's fluid dynamics inside the human body.
Now, we've been talking heavily about the pure medicine. But segment 5 of the source material completely zooms out. It's titled Context is Everything. It argues that the decision to cut isn't just about the patient lying in front of you, it's actually about where the patient is lying.
This is the sociology of surgery, and it's fascinating to think about. The source sharply compares a massive tertiary center, like a major university hospital in a city, with a small district hospital or a rural clinic.
In a big city hospital, you have literally everything. Massive ICU, 20 specialists on call, surgical robots.
Right, you have an incredible safety net. If you decide to wait and watch with the drip and suck method and the patient suddenly deteriorates and goes toxic at 3:00 a.m., you have a fully staffed ICU team, an anesthesiologist already in the building, and a fully prepped OR ready to go in literally minutes. You can afford the luxury of being patient.
But if you're in a tiny district hospital,
Imagine you are the sole surgeon for 50 miles. There is no ICU. The one anesthesiologist is at home asleep, 20 minutes away. If that patient suddenly crashes at 3:00 a.m., they might simply die before you can physically assemble a team to help them.
so you just can't take the risk of waiting.
You can't. Your threshold for taking them to surgery drops dramatically. You choose to operate earlier.
Is that considered bad medicine? To operate when maybe you didn't absolutely have to yet?
No, the source passionately argues it is incredibly wise medicine. It's pragmatic, safety-based medicine. You are dynamically tailoring your clinical decision to the harsh reality of the resources you actually have. You choose to operate early to actively prevent the catastrophic crash you know you cannot handle.
That makes total sense. But I had honestly never thought about how the actual building and the zip code dictates the treatment plan just as much as the disease.
It absolutely dictates it. The source also shares a great anecdote about working with low tech in those environments. No fancy CT scanner, just your bare hands and a plain old X-ray machine.
Which probably sounds completely terrifying to modern young doctors.
Oh, it does. But the senior surgeon argues that it forces you to sharpen your basic skills. If you can't rely on $1 million machine to see inside the body from you, you have to rely heavily on your hands. You have to really feel the abdomen. You have to track the minute clinical signs much more closely.
This beautifully leads to the concept of volume and instinct. The source talks about surgeons in busy government hospitals seeing 10 severe obstruction cases in a single night shift.
That intense volume creates deep pattern recognition. This is what we colloquially call a gut feeling.
We hear that phrase all the time in every profession, trust your gut. But in surgery, is it real or is it just a form of confirmation bias?
In experienced surgery, it's highly real data processing. When a veteran surgeon walks into a room, takes one look at a patient and says, I don't like the look of this guy, they aren't using magic or mysticism. Their brain is just subconsciously processing 1,000-minute microcues instantly.
Like the smell we talked about.
The smell, the exact pallor of the skin, the specific rate of shallow breathing, the subtle way the patient is holding tension in their belly. The brain instantly matches this complex pattern to the 5,000 similar cases they've seen over their career and instantly flags it as severe danger.
So instinct is really just vast experience moving much faster than conscious, rational thought.
Exactly. And that's exactly what this source material is trying to transfer to the listener, a small piece of that massive database of experience.
We have covered a truly huge amount of ground today. From the dangerous physiology of third spacing, to the horrific smell of feculent vomiting, all the way to the fluid dynamics of the Gastrografin challenge. Let's try to crystallize this for you. We're going to do segment 6, the rapid-fire pearls.
Let's do it. High-yield facts to take away.
Most common cause of a small bowel obstruction.
Adhesions from prior surgery in adults. Hernias in the developing world where surgeries are less common. And intussusception in children.
X-ray signs. How do you tell small bowel versus large bowel?
Small bowel obstructions show up centrally on the X-ray, with a distinct ladder pattern of lines going all the way across the width of the tube. Large bowel is peripheral. It literally frames the outside of the abdomen and has these pouches called haustra that don't go all the way across the width.
The coffee bean sign.
That's a sigmoid volvulus, a twisted large bowel.
And the primary treatment for that twist.
Internal decompression with a flexible tube first. Surgery is only if that clever trick fails or if the bowel is already dead.
And finally, the absolute non-negotiable triggers for immediate emergency surgery that do not pass go signs.
Strangulation, peritonitis, and a closed-loop obstruction.
Boom.
Simple as that. If you see those, you cut.
As we finally wrap up this deep dive, I want to reflect on the outro of the source material, because it actually ends on a surprisingly philosophical note for a gritty surgical text.
It really all comes back to humility.
The idea that despite all our incredible modern technology, the CT scans that can slice your body into millimeter-thin digital images, the highly advanced surgical robots, the single most important tool, is still the basic clinical exam.
Hands on the patient, talking to the patient, remembering to ask about that faded appendectomy scar from 30 years ago.
It's a profound reminder that medicine is still, at its core, a deeply human discipline. It's not just a flowchart or an algorithm.
And the final thought of the piece really stuck with me. The best surgeons in the world aren't the ones who can cut the fastest or the flashiest. They aren't the cowboys.
They're the ones who know exactly when not to cut.
Exactly. Having the sheer discipline to sit on your hands, to employ drip and suck, to wait and watch a patient suffer in pain because you deeply know it's the safest thing for them in the long run, that takes immensely more courage than just rushing to operate.
The terrifying silence of an ileus versus the frantic tinkling of a mechanical obstruction. It's an auditory language that takes an entire lifetime to truly learn.
And hopefully today we helped you learn just a few critical words of it.
I certainly learned a lot. But I have to leave you with one final, totally separate thought to mull over. We talked about how that famous surgeon's gut feeling is really just high-speed pattern recognition, right?
Right.
Well, what happens when artificial intelligence truly steps into the emergency room? Because if there is one thing AI does infinitely better than a human brain, it's processing massive amounts of pattern recognition data. Will an AI eventually be the one making the call to cut or not to cut? Or does the deeply human element, smelling the room, feeling the tension in a patient's muscles, provide some kind of vital data that a machine can never, ever process?
That is a fascinating and terrifying question for the future of surgery.
Something for you to think about next time you're in a hospital. I'm going to go drink a lot of water right now and truly appreciate my peristalsis.
Good plan. Keep things moving.
Thanks for joining us on this deep dive. We'll see you next time.